And now it is my pleasure to introduce tonight's speaker, Dr. Jordan Ford. Dr. Ford was raised in West Virginia and earned his undergraduate degree in psychology from Harvard University. He worked for 3 years as a research coordinator at the New York State Psychiatric Institute's Anxiety Disorders Clinic, but ultimately decided to pursue a career in veterinary medicine. After obtaining his doctorate from Cornell University, Dr. Ford completed an internship in small animal medicine and surgery at the Animal Medical Center, and he's now AMC's first resident in dentistry and oral surgery. AMC's dentistry service remains the only such specialty service in New York City, and Dr. Ford is excited to support the department in setting the standard for veterinary oral health care. And we are so excited to have him with us tonight to lead tonight's event. This is Dr. Ford's second Usdan lecture, and he's also given several presentations for our Vet Camp Children's Program. Dr. Ford, Kimberly, and I just want to say how much we appreciate all of the wonderful support you've given us. Thank you again. And on that note, please welcome Dr. Jordan Ford.
Thank you very much for that introduction, Michelle, and thank you and Kimberly both for continuing to invite me back and to the Usdan Institute for hosting the lecture. And thank you, of course, to all of you who are virtually present tonight in honor of February being Pet Dental Health Awareness Month. So on that note, we're going ahead and start this evening. So my lecture last year was really about what veterinary dentistry and oral surgery as a specialty service means. But I thought for this year, I'd like to narrow it down a little bit and make it a little bit more applicable kind of to the average pet owner. So to that end, what I hope to accomplish this evening is to kind of clarify what we mean just by dental disease. It is actually kind of an umbrella term that encompasses a number of different disease processes. And to better understand those, I'm going to give a brief overview of relevant anatomy and pathophysiology. And I hope that all of that conversation cumulatively will help you better understand any treatment options that we may recommend if you come to see us. So kind of a trajectory for this evening, we're going to talk about dental disease, what follows or falls under that term, prevalence within veterinary species, and we're going to talk a bit about the periodontium and the tooth itself in health and disease both. We're going to talk a bit about recognizing signs of oral disease in our dogs and cats primarily, and then some resources that I do think any pet owner should be cognizant of even after this talk. And then of course, we'll have some time for questions at the end. So dental disease, what are we actually talking about? It is as simple as the term seems. It is actually pretty variably defined sometimes, especially in our what handful of larger epidemiologic studies we have in veterinary medicine. I do want to point out 2 studies in particular because they are actually unusually large for veterinary studies. They are multi-hospital and multi-state studies, both of them. And the first one is Banfield's sort of State of Pet Health report, particularly the 2016 edition, in which they define dental disease a little bit more broadly as any health issue affecting the mouth. In general, this mostly still meant the more common forms like periodontal disease and dental fractures and endodontic disease, and we'll parse all of that later. But it also maybe included some less common things like stomatitis, which fortunately we don't see all that often in dogs and cats. Nevertheless, a huge number of pets were involved in this study, 2.5 million dogs, of which over 3/4 had some evidence of dental disease as defined in this study. So very, very common. And you can see that they did note of the more common breeds that were enrolled, our Dachshunds, our Yorkies, our Shih Tzus, our Maltese, very common dogs in New York City. All of them are very, very affected by dental disease. So it's something that needs to be on your mind if you're a pet owner with those dogs in particular. We'll discuss why they're particularly predisposed in a bit. Cats as well. So I do want you to note that only 500,000, still a lot, but many fewer cats were involved in this study. And that's really an unfortunate pattern that we've seen historically and currently in veterinary medicine. There are actually more cats in the United States than dogs, but they are, for unfortunate reasons, kind of believed to be easier keepers. They are not presented as frequently for the veterinary attention that they do deserve. And we can see because those 500,000 cats, 68% of them also had evidence of dental disease, so nearly as many as the dogs. Similar study, 17 years prior, a little bit more restrictive in terms of their definition, but even if we're just looking at dental calculus and gingivitis, which we'll explain that are really kind of signs of periodontal disease, even with that narrower definition in this study, still, these were the most common findings on physical exam, period. So of over 30,000 dogs, 40% had these signs, and of about half as many cats, 15,000, had almost as much, so 37.3% of those. With regard to the nature of the data that they were gathering in both of these studies, it's important to note that these are actually conscious physical exams. So these are just your normal kind of in-exam room conversation with your veterinarian. And when we're talking about dental disease in particular, we need to be aware that conscious examination is always going to be, almost always going to be, an underestimation of the actual presence of disease. That's why I do like this infographic that the American Veterinary Medical Association put out in honor of Pet Dental Health Month. So we have our tooth in the form of an iceberg, and that's because most dental disease occurs below the gum line where it's hard to see. So 2/3 of the tooth is the root. That's not available for visible inspection. The periodontium, not available for visible inspection, mostly. So if we take these numbers where we already know that dental disease is still the most common finding, and we assume that it's still an underestimation of the actual presence of that disease, then we can conclude, I think, pretty safely that it's ubiquitous no matter how we define it, and certainly worthy of our attention. So I've said the periodontium a few times, and it's not necessarily a word that's used commonly outside of a medical environment. So what exactly do I mean by it? It's really periodontal anatomy. So there are 4 types of tissues that compose the support system of the tooth itself. It's a little bit artificial to divide the tooth and the periodontium. They're really 2 parts of the same functional unit, but it's useful to consider them separately. So when I talk about the periodontium, I mean what is shown in this cross-sectional image here. So we have our tooth, but we also have kind of the socket and everything else that is surrounding it and holding it within the jaw. So the tissues, the 4 of them that compose the periodontium, are the gingiva, so the gum tissue there. Even in health, there's what we call the gingival sulcus. So there's a little bit of a cup there against the tooth surface. This white part of the diagram here is enamel, so the hard part of the tooth that we're all familiar with because it's what we see when we look in the mirror every day when we're brushing our teeth. But below the gum line, once we're past the so-called cemento-enamel junction, we actually don't have enamel anymore. We have a different hard tissue called cementum, and we'll talk about that a little bit later. So we have gingiva, cementum, and then between the alveolar bone, so the bony socket in which the tooth rests, and the cementum is the periodontal ligament, so the fibrous attachment. So those 4 components compose the periodontium. And when we talk about periodontal disease, we're talking about progressive attachment loss between the tooth and its support structures. So when we have active destruction of those tissues, when this sulcus becomes unnaturally deep, so we get a progressive periodontal pocket moving slowly, sometimes not so slowly, but toward the extent of the root of the tooth, we call that periodontitis. We do have periods of quiescence, so it's kind of a waxing and waning process, but it is kind of a constant march. We don't intervene regularly. It is a progressive disease. And talking a bit more about the nitty-gritty of the pathogenesis of periodontal disease, it's frustrating to think about because it is immediate. It is constant. It's almost insurmountable. That's why we brush our teeth twice a day, every day, and we should still go to the dentist regularly because it is an ever-present threat to the health of our teeth. Initially, even immediately after brushing your teeth, immediately after an ultrasonic scaling with your dentist, within seconds, the process starts over again. So within saliva, normally, there are these molecules of glycoproteins, and they immediately start to settle onto the tooth surface in what we call as a dental pellicle. Within hours, that pellicle begins to become colonized with bacteria that normally reside within the oral cavity, and then we start to develop plaque, so plaque biofilm, which we're probably all familiar with, at least to some degree. This image on the right is actually kind of electron photomicrograph of a tooth surface. So this white is the tooth itself, this tan color is that unpleasant plaque biofilm, and then these are bacteria that are starting to take root there. So if we don't kind of continually remove that biofilm, even as soon as 24 hours after that initial colonization, we start to see a change in the bacterial population there. That's because if we consider again that sulcus, deeper within the sulcus, if we start to have it become kind of filled with plaque biofilm, that depth within the sulcus allows an oxygen-deprived environment, which allows gram-negative anaerobic bacteria to begin to colonize there. These bacteria are more concerning from a disease perspective. They produce compounds that are more destructive to the periodontium. They're much less friendly than the gram-positive aerobic bacteria. They also produce or tend to produce volatile compounds as waste products that have a lot of sulfur in them. So when we start to notice halitosis, that's kind of a clue as to what's going on. If we still don't intervene, we start to get gingivitis within 24 to 48 hours. Fortunately, that inflammation of the gingival tissue or the gums, that is reversible if we start to intervene. If we continue to not act, then 48 to 72 hours later, we start to have mineralization of that plaque biofilm. So even within the saliva normally, there's a fair amount of calcium, and that calcium starts to precipitate out and get into that plaque biofilm, and it starts to mineralize to form calculus or tartar. Once we get to that stage, then we are kind of further losing the battle because mineralized calculus is much more difficult to remove than plaque biofilm. It's more irritating to the soft tissues in the mouth, so it just makes disease a little bit more persistent. If we continue to let this disease process progress, then we start to get pocketing and attachment loss. So again, that attachment loss, in contrast to the gingivitis, is not irreversible. So if we start to get deeper and deeper pockets between the tooth and its supporting structures, we cannot regain that tissue, unfortunately. So it behooves us to intervene. In terms of cofactors, so things that make periodontal disease worse in veterinary species, a lot of it is breed dictated. So in general, small breed dogs are going to be more predisposed to periodontal disease than large breed dogs, than a dog that more closely resembles its wolf predecessor anatomically. And the reason for that is when we were breeding dogs to be smaller and cuter, unfortunately, we shrank their skulls a lot more rapidly than we shrank their teeth, if that makes sense. So a small breed dog is always going to have what we call kind of an unfavorable tooth to jaw ratio. Their teeth are going to be kind of disproportionately larger for their jaw anatomy relative to something like a Labrador or a German Shepherd. That disproportionate ratio, it makes the teeth more crowded in general, and anything that causes crowding promotes plaque retention, which propagates periodontal disease. Similarly, certain breeds, so our brachycephalic breeds or our short-muzzled breeds, French Bulldogs, English Bulldogs, Cavaliers, again, when we made these changes to their anatomy with selective breeding, we ignored the teeth to our own detriment and to theirs, unfortunately, because when we shorten the muzzle, then the teeth now start rotating and stacking on each other in ridiculous ways sometimes. And again, that's plaque retentive. It will perpetuate periodontal disease. Certain breeds, even if they don't have a conformation that is particularly promoting a periodontal disease, seem to be just more affected. So Abyssinian cats, Somali cats, some Maine Coons, they tend to have their own kind of anecdotally much more severe forms of periodontal disease for reasons not entirely understood. Even larger breed dogs like sighthounds, greyhounds, they are prone to periodontal disease, even though they're more of a larger conformation. So it's something that there is a breed association, even in the absence of a facial conformation that is not in their best interest. Another cofactor is persistent dentition. So when we have deciduous teeth, dogs and cats have deciduous teeth, as we do. And you can see in this image here on the right, this is actually a persistent deciduous left maxillary canine tooth. So that baby tooth has very much overstayed its welcome. It should not coexist with the emerging adult here. And you can see already that there's a little bit of debris accumulating between those teeth. Again, plaque retention, anything that is plaque retentive will set us up for failure for periodontal disease. So persistent deciduous teeth do need to be removed. Even on the individual basis. There is a kind of, even between, let's say we have two dogs of the same breed, two Labradors, one may be kind of resistant to periodontal disease and one may be very, very affected. There is an individual basis to the host immune response to periodontal disease that unfortunately contributes to the disease pathogenesis. So if an individual dog or human or cat is just very inflammatory in its reaction to that plaque biofilm, unfortunately, that inflammatory reaction can also do some sort of poorly directed, nondescript, or kind of collateral damage to the host's own tissue. So they don't do themselves any favors if they're very reactive to the plaque biofilm. Other things, just like poor systemic health in general, advanced age, all of those things are going to be cofactors as well. Why do we care? We should care. So from the human side of things, it's much better studied. That's kind of the trend in general. Human medicine, they always have much better research and data than we do on the veterinary side of things. So we kind of have to do some reverse extrapolation, but there have already been convincing studies demonstrating a relationship between advanced periodontal disease in people and things like preterm birth, low birth weight, cardiovascular disease. They found periodontal pathogens in atherosclerotic plaques in people, which is vile to consider. Neurovascular disease, pulmonary disease, and advanced periodontal disease also antagonizes our ability to control diabetes in people. So there are a number of very unpleasant consequences, and it makes sense if you consider your local anatomy. The mouth is a very well vascularized place. There's a lot of blood flow to the mouth, which is great from an oral surgical perspective because it means we heal a little bit more rapidly. When we talk about periodontal disease, though, when we have significant damage to the periodontium, when it's no longer an effective barrier between all of the bacteria within the mouth and systemic circulation, it becomes a nice gateway for all of those plaque bacteria, all of those inflammatory mediators, all of that disgusting mess can just go right into a neighboring blood vessel and then zoom off to wreak havoc elsewhere in the body. On the veterinary side of things, we don't have as much direct experimental evidence or research data supporting similar relationships. I don't think that's reason enough to pretend that those relationships don't also exist. At the end of the day, a mammal is a mammal is a mammal. So in a lot of ways, from a comparative medicine perspective, I think it's much more appropriate to assume that we do have these systemic consequences in our dogs and cats, and that it does serve their systemic health to get rid of festering inflammation within the mouth. So in terms of consequences that are more local, so less systemic, of course, we have tooth loss. If we don't intervene in progressive attachment loss, then ultimately the teeth will fall out, which is disappointing. But there are more significant local concerns as well. We can get facial abscessation, so we can have kind of eruptions through the cheeks with some unpleasant draining tracts. Those are more commonly associated with endodontic disease, which we will talk about, but we can get true periodontal abscessation as well. Oronasal fistulas. So in small breed dogs especially, dachshunds are actually the poster children for this. So their maxillary canine teeth, those large teeth in the front of their mouths, the shelf of bone between those teeth is very thin. And if we allow periodontal disease to run wild, then that bone can be eroded completely. And then we have a nice hole or a fistula between the oral cavity and the nasal cavity. So everything that was already disgusting about periodontal disease now has access into the nasal cavity where it does not belong. Additionally, things like food, hair, dirt, all sorts of filth can take months, years, sometimes to find these. And we just have all of that debris being shoveled into the nose for a significant amount of time sometimes. So when we start seeing disgusting nasal discharge, sometimes nosebleeds, then I would say check the teeth, because sometimes it is related to periodontal disease. These dogs, they smell so terrible. This is preventable. We should intervene. We don't need to have this. Kind of one of the worst case scenarios, and I have seen several cases like this in my residency so far. I'm only halfway through. Again, tends to be a small breed dog thing because their teeth compose such a large portion of the structure of their lower jaws. if we allow periodontal disease to progress, we can actually get pathologic jaw fractures. So a force that might otherwise be pretty benign can strike a weakened jaw and cause fracture. So that's what we're seeing on this image on the right. This is a 3D reconstruction of a CT. This is a little chihuahua, I believe. We can already see that most of the teeth are gone from the upper jaw. When we look at the lower jaws, I can already tell we've got some bone loss on these teeth, but as we look further forward, we have this huge step down because we have a complete fracture through this left mandible. And we also have a complete fracture on the other side as well. So this poor dog's jaw was probably just hanging slack because the periodontal disease has caused so much disease in the bone there that both of its mandibles have broken. Fixing jaw fractures is challenging at the best of times because of the biomechanics of the mouth. It's a very mobile place and it's difficult to stabilize those fractures even when we have healthy bone. When we barely have any bone left at all and what we have left is diseased, that only sets us up for failure. It only makes the whole repair process much more difficult, and sometimes we can't repair these, which is very heartbreaking. Again, these are preventable. So been a bit gloom and doom about gum disease so far. So let's talk about diagnosis and treatment, because these are very treatable and preventable diseases between the beginning and the end, like we've just talked about. So just a matter of being aware and getting the appropriate treatment. Before we can treat disease, we have to diagnose it. That's a kind of a basic tenet of medicine and surgery outside of dentistry, but stands true here as well. At the AMC, we've adopted the term that's been proposed elsewhere, Comprehensive Oral Health Assessment and Treatment, with the acronym COHAT. It is a little bit of a clunker as far as acronyms go. It's not very sweet to the ears, but it covers a lot of ground diagnostically. So it's pretty difficult to come up with a succinct acronym for everything that it covers. When we talk about veterinary dentistry, before we move forward, all of our patients have to be under general anesthesia. We'll talk a little bit more about that at the end of the lecture, but just so we all know, it's a requirement. And once we have them safely anesthetized, then we can do full mouth intraoral radiography. That's what we see right here, our dental x-ray unit, this kind of gooseneck, similar as in your dentist's office. So each and every tooth gets a dental x-ray. We do a periodontal treatment, again, similar in human dentistry, where we get an ultrasonic scaling around each and every tooth. And then we do periodontal charting with a periodontal probe. So we go around and measure and analyze each and every tooth. Then and only then can we intervene based on our cumulative diagnostic data. And I have this in the periodontal disease section, but really for any of the most common dental diseases, this is still kind of the minimum baseline. So we would have COHAT before anything else. So just kind of to elaborate a little bit on each of those steps, here's a full mouth series of a dog, 42 teeth in health in the adult dog's mouth, and each and every one of them is radiographically examined. Again, because 2/3 about of every tooth is under the gum line, so I can't see it without the assistance of dental x-rays. Similarly for the cat, full mouth series, cats only have 30 teeth in adulthood compared to the dog's 42, but nevertheless, each and every one is included. Then we have our dental chart here, and this is an example of our periodontal probe. So these have tick marks corresponding to various millimeter depths, and we truly do go around each and every tooth, march it along gently, and see just how much attachment we've lost along every tooth. You can see in this diagram here between these two dog teeth, it's quite a deep pocket there. So once we have all of that diagnosis done, then we can finally intervene, and we stage periodontal disease from 0 to 4, and that's really based on the severity. So 0, clinically normal; 1, gingivitis only, again, reversible. So great, if we can just do a nice deep cleaning, a periodontal treatment, we can get rid of that gingivitis. Stages 2 through 4 are early, moderate, and advanced periodontitis. So we cannot reverse this attachment loss, unfortunately, but we still can intervene in some cases. I want you to take a look at this image on the right. So this is a greyhound. So again, a large breed dog, but even on visual examination, clearly very affected by periodontal disease. So this fourth premolar here and this first molar here, you can see where the enamel ends clearly, and you can see just how much tissue we've lost, or you can get an approximation, I should say, of just how much tissue we've lost. This third premolar, maybe he looks a little okay. He's dirty, but we can clean him up potentially. But we can't say for sure until we have x-rays. And thankfully we do, because the situation is actually much worse than based on this photo. So this first molar here, he's represented in this x-ray. That distal root, that back root, there's nothing, it's floating. It's floating in a cup of yuck, and you would have no idea just looking at the tooth there. So this guy's got to go. Similarly, that fourth premolar, way more than 50% attachment loss. Everything is supposed to be way up here. So he's a goner, nothing we could do about it. Third premolar, still some attachment loss, probably about a quarter, but we may call him, stage 2-ish, 2-3. Doesn't have to necessarily leave right now. And that's exactly what happened. So those two teeth did have to go. The third premolar was allowed to stay because it's periodontal disease, not reversible, but not as poorly off as the other two. So exodontics, extraction, that is our most common treatment. And for many, many teeth, that is the only treatment. If we get to stage 4, it's game over. We can't turn back time. There's nothing that I can do to make that floating root reattach. That tooth is probably already dead. That being said, for teeth that are not as severely affected, have not lost as much periodontal attachment, there are other things we can do that don't necessarily rely on extracting the tooth. So root planing, we can take a curette and gently go in and reach a pocket that is a deeper one than we could get with the ultrasonic scaler. So we can go in and kind of scrape out, curette out all of that plaque and calculus and debris and really clean out that deep periodontal pocket. With resolution of inflammation in those soft tissues, sometimes we can actually get the pocket depth to shrink a little bit. So we can get some pocket reduction just with root planing. Another treatment that has been offered historically is application of perioceutics. So it's kind of injecting this kind of polymer matrix material into deep periodontal pockets. That material is impregnated with antibiotics, and the idea that kind of a slow release local antibiotic therapy may be helpful in reducing pocket depth. Dr. Martel, one of our dentists here, actually did a study showing that that's not so much helpful, not so much the case in veterinary medicine. So we don't rely on that procedure that much anymore. It's not harmful, but it doesn't seem to be all that helpful. We can perform more advanced kind of periodontal flap surgeries. So we can actually take the gum line essentially and kind of move it a little bit lower as a means of making the periodontal pocket shallower and more amenable to home care and treatment. Notice I said home care. So if we do these advanced treatments, everything else I'm going to talk about for periodontal treatments, these procedures rely on a commitment from the client to come back for regular professional treatment, maybe as often as every 3 to 6 months, and earnest home care, which we will talk about. If your pet will just not accept home care no matter what, if your pet is not a good candidate systemically for repeated anesthetics, if you cannot afford them financially, that's fine, but it just means we shouldn't pursue these procedures. Everything that we talk about tonight when we talk about advanced kind of things beyond extraction, it always has to be couched in a consideration of the individual tooth, you, the client, and your patient, the pet, my patient, your pet. And if we can't get kind of a consensus amongst all of those needs, then perhaps these procedures aren't the best choice. Nevertheless, they are available. One more that we can talk about for advanced periodontal disease is guided tissue regeneration, and that's kind of what's demonstrated in these images on the right. So if we have a very deep pocket, usually on a more structurally important tooth, we can open up the soft tissues. We can, again, curette out all of the disgusting plaque, etc., from that pocket. And then we can actually fill the pocket with a slightly demineralized bone graft material. We have to protect that bone graft with a membrane because otherwise these soft tissues will kind of immediately invade that graft. And what we want to allow is the cells within the local bone called osteoblasts, they need time to migrate into that graft and then potentially form new bone, using it as a scaffold. So in that way, we can actually regain, in some cases, some bony height and bony coverage of these roots. We don't do it all that often, but I actually got to do this case that we're looking at the x-rays of just last month. It's a Cavalier King Charles Spaniel, so a predisposed breed. And you can see this fourth premolar here. Again, this one's a goner. We're way past 50% bone loss on that distal root. So I extracted that tooth. But this first molar, still significantly affected, still about 25 to 50% attachment loss there, but it's a big tooth. Otherwise, it looks to be in pretty good shape. And it does occupy a lot of this mandible here, so it would be a bit of a struggle to extract. So the client was motivated to do whatever possible to preserve that tooth. And it's actually kind of unrewarding radiographically to show you the aftershot, again, because this graft is demineralized, so it's going to be less apparent on radiographs, unfortunately. But maybe you'll believe me when I tell you that this kind of speckled material here is the bone graft that I placed in that defect and then closed it up. So we can hopefully regain some bone height there. Again, though, I'm asking this client to bring this patient back in 6 to 12 months for another anesthetized cleaning and examination. I'm asking this client to brush this dog's teeth. If that sounds like a commitment you are not interested or unable to do, that's fine. We just can't do this sort of advanced procedure. We have to be all on the same page. So home care, let's talk about home care. I've alluded to it several times. It is a hard sell in veterinary medicine. It's not really on the public's mind yet. So I get it, that I understand when you look at me like I'm crazy when I say, why don't you consider brushing your dog's teeth? Nevertheless, toothbrushing is always going to be the gold standard in preventing the progression of periodontal disease. That's why we brush our teeth twice a day, every day throughout our lifetimes, because it's effective. We'll talk a bit more about it on the next slide. Everything else that we have is somewhat in decreasing order of efficacy. So we have dental diets, we have dental treats, we have chews, water additives, supplements. So if either your animal will just not accept toothbrushing no matter what, or if you are brushing, great, and you just want to do literally everything possible to prevent further progression of periodontal disease, we can throw the kitchen sink at them. Great, we have all of these tools in our sort of toolkit. All that being said, the veterinary market, the animal product market, is unfortunately pretty unregulated. So to narrow down your choices as the consumer, I would recommend checking out the Veterinary Oral Health Council. So the VOHC is a group of veterinary dental specialists to whom manufacturers of products can voluntarily submit data, and the council can then review that data and say, okay, yeah, there's convincing evidence that there's at least a modicum of benefit from this product. So if you're going to start exploring these types of products, I'd recommend visiting this website. They have lists of approved dog products, approved cat products. Great, use it as a shopping list if you're interested in incorporating these things. I think minimally, dental chews are a great way to substitute something that you're probably already giving your dog, and just having a product that's a little bit more targeted toward preventing periodontal disease is an easy introduction. So toothbrushing. It is the gold standard. And I think the problem is that some people, even if they do get curious and try it, their approach is to take a flying leap with a toothbrush at their dog's mouth who has never seen a toothbrush before, and unsurprisingly, no one has fun. So we have to consider it as much a behavioral intervention as a dental one. So it's really just about getting everything you need and introducing things in a stepwise way, and really just taking everything as painstakingly slowly as possible so that all these new novel things are innocuous. So getting ready for toothbrushing, sort of collecting what you need. There are veterinary toothbrushes available. Unfortunately, again, a lot of them tend to be a little bit more stiff bristled than is comfortable for a lot of patients. So we usually recommend just going to the drugstore and getting a pediatric human toothbrush. So the softest bristle you can find. If it has a cartoon character on it, great. And you don't really even need toothpaste for veterinary species. So toothpaste doesn't serve the same function. It's not fluoridated because we're not as concerned about cavities or dental caries in veterinary species. It's really about the mechanical action of removing that plaque regularly with a toothbrush. So you can just use a toothbrush in warm water if you don't want to bother with a toothpaste. Some of the veterinary toothpaste do have enzymes or sort of mineral chelating agents that maybe prevent some progression from biofilm to calculus. Really, I would view them as a training aid. Most of them just taste delicious. They're poultry, seafood, malt, whatever works, whatever is really appealing to your dog or cat. And then just take a whole week, take 2 weeks, just put a little bit of the toothpaste on your finger, let them lick it off, walk away. It's a delicious treat with no negative connotations. After you've gotten them to the point where they're enjoying the toothpaste, they're looking forward to it. Maybe the next week you will lift up the cheek and swipe the toothpaste along the gum line. That's it, walk away. Just really make it a slow build up and kind of sneak up on them, not in the literal sense, but just kind of build up slowly to what you're actually working toward. When you finally get to the point of introducing the toothbrush, I don't think it's necessarily as demanding or onerous as people think. It's not necessarily the same motions that or the same complexity as in ourselves. So dogs and cats, their occlusions normally are what we call a scissor bite. So the way their teeth interact tends to be a little bit more self-cleaning than ours on the inside surfaces. So the lingual side or the palatal side, those tend to not accumulate calculus as much in veterinary species as in people. So if you can work toward just getting the outside surfaces, so the buccal or the cheek aspects of all of the teeth, 30 seconds per side, at least every other day, or remember, we have that window from plaque to calculus. If we miss that window, we can't brush away the calculus, we're wasting our time. But if we can accomplish that at least every other day, then it will do a lot of good, especially for patients that are predisposed to periodontal disease. So this video, it's a snippet of a video that's available, I think, through Usdan. And that's our Dr. Carmichael there with, I believe, a staff dog. And that's really just kind of the motion that ultimately you're going to want. And I think kind of what I recommend to clients, just kind of setting yourself up, is having your pet kind of in your lap, their back to your chest. You can use your non-dominant hand to cradle their muzzle. And then once they're no longer afraid of the toothbrush, you can use your dominant hand just to get those cheek sides of the teeth. It doesn't have to be a battle. All of that being said, if you try it and it doesn't work out, I would rather you not persist than damage your relationship with your pet. It's you know, we want to preserve your relationship with your companion animal above all things. So if it's a deal breaker, then don't push it. That's okay. So that's mostly periodontal disease and the periodontium, which is, again, the bulk of dental disease at large, but we do need to talk about the tooth itself. We certainly can't ignore it. In terms of dental anatomy, so this image on the right is a right mandibular canine tooth in a cat, and we can break the tooth down into the crown above the gum line and the root, which is the majority of the tooth below the gum line. And the crown and the root are composed of 3 different hard tissues. So we've already touched on enamel. It's a very, you know, maybe you can perceive it, it's a white outer surface there in the crown, so that's the enamel. We've already mentioned the cemento-enamel junction, so once we go below the gum line, that enamel is no longer present, it's now cementum around the remainder of the root. But the bulk of the tooth is actually a hard tissue called dentin. And to kind of differentiate all of those, so this is actually an electron micrograph of enamel. So enamel is the hardest substance in the body. Human, dog, cat, it's much more densely mineralized than bone. 96% inorganic material, and it's essentially composed of stacks and stacks of crystals, so mineralized crystal structures. Historically, they were called enamel prisms because they kind of resembled a prism, but I guess a prism apparently has a very specific geometric definition and it's not actually accurate. So nowadays we call them enamel rods. Nonetheless, you can see that there are many, many, many small rods of enamel here, and those are all stacks and stacks and stacks of crystal material. And that's how we get that tremendous strength that we need for enamel. It makes sense. Think about your own teeth. You are, you know, just daily mastication, chewing your food. That's a tremendous amount of force grinding your teeth together. And enamel is up to the task of resisting a lot of that force. All of that being said, the trade-off for the strength of enamel is that it is somewhat brittle. So it has no elasticity to it. So if we have a physical force that is enough to deform it, it does not have enough elasticity to deform and then recoil. It instead shatters like glass. So it is quite brittle, unfortunately. Dentin underneath it, though, a little bit less mineralized, so about 70% inorganic material, but still harder than bone. The dentin underneath, being a little bit less mineralized, can actually help to kind of absorb some of the shock that the enamel might endure in the day-to-day. And dentin, when you look at it grossly, visually, it appears to be a solid material. But if we look at it again at this degree of magnification, it is actually perforated by many, many, many tubules. There's been a study in veterinary medicine looking at dog dentin in particular, and apparently if we expose just 1 square millimeter of dentin, that may expose up to 52,000 dentinal tubules. So they are very, very small, but they are many. Dentin is a totally tubular substance. And so we have to think about that clinically. It is important when we talk in subsequent slides. You'll notice here potentially in this image that there are kind of these little arms sticking out of these tubules, and that's because each and every one of these tubules has what is called an odontoblastic process within it. That's actually kind of a filamentous arm of a cell type that resides in the pulp that we'll talk about in a little bit. And finally, we have cementum, which again covers the root. It's less interesting histologically, so I don't have an image of it. It's a little bit less mineralized than the other two, closer to bone. Nevertheless, the hard tissue that attaches to both the periodontal ligament, which then leads to the alveolar bone. The pulp itself is the central soft tissue of the tooth, and this actually narrows with age. So in younger animals, the pulp cavity is actually much wider, and that's because within the pulp cavity, we have vessels, we have nerves, we have connective tissue, we have fibroblasts that are the cell types that kind of create and maintain that connective tissue matrix. But that is where these odontoblasts, so those cells whose little arms stick out through those tubules, they reside within the pulp along the periphery of the pulp cavity. And throughout the life of the tooth, they continue to lay down dentin. So that pulp, and it will recede. So it's called pulp recession. It gets narrower and narrower with age. So it gives us some sense of a patient's age if we see dental radiographs and we see how wide that pulp cavity is. It also lets us know if a tooth has died somewhere along the way. If every other tooth in the mouth has a cavity that is yay wide and one tooth has one that is very wide, that tooth expired, unfortunately, when it was much younger. In addition to the odontoblasts, we also have some immune cells and some undifferentiated cells as well in the pulp. So cells that are actually precursors and can become fibroblasts or odontoblasts as needed. And then finally, at the very tip of the root, we have the apex. So there is a hole or a series of holes there through which those blood vessels and nerves all enter into each and every tooth. So teeth are living structures. We just don't tend to necessarily think of them like that. So what happens when that structure is disrupted? So when we talk about dental trauma, also incredibly prevalent. So there are studies showing that no matter how we really define it, up to a quarter, a little bit more than a quarter of dogs and cats have some form of dental trauma. There are more types than are pictured here, but they're less common, so we're not going to discuss them at length tonight. But when we talk about dental fractures in particular, we define them based on the tissue type that's involved and then the portion of the tooth. So sometimes they're very superficial and only involve the enamel. Sometimes they involve both the enamel and the dentin, in which case we call it an uncomplicated fracture. Whether that's just a crown fracture or a crown root fracture, we can have a crown root fracture that avoids the pulp. If we do get into the pulp, then we call it a complicated crown or crown root fracture, depending upon the portions of the tooth that are involved. That is clinically relevant. We'll talk about it in a second. Things other than fracture that aren't necessarily thought of as like acute trauma, but chronic trauma. So things like abrasion and attrition. So dogs primarily, if they are chewing constantly on foreign material that is too hard, whether that's a chew toy or a tennis ball, they are famous for this. It can actually wear away the teeth like sandpaper. And attrition is essentially the same process. It's just if they have a malocclusion and the wear is from teeth grinding against one another. So a somewhat small difference. If we do have pulp exposure through fracture or severe abrasion, then not only do we have pain, but we have to think about endodontic disease. So how does endodontic disease contrast to periodontal disease? What I mean by endodontic disease is when we have exposure of the pulp, then all of the normal bacteria that reside within the mouth then have an avenue into that tooth that was previously a relatively sterile environment. So the bacteria can enter into that pulp tissue. They can cause pulpitis or inflammation of the pulp, and then pulp necrosis or pulp death potentially. And once that pulp material dies, then we get sort of an efflux of all of that inflammatory material and bacteria out of the apex of the tooth, and we get periapical disease. So that's kind of what endodontic disease looks like as a pathway. Interestingly, so historically, we've kind of thought that uncomplicated fractures are a little bit less important because we don't have pulp exposure, but Dr. Carmichael, one of our other dentists here on the service, was actually a co-author on a recent study showing that dogs with uncomplicated fractures referred to dental specialists, I think over a quarter of them had radiographic evidence of endodontic disease. Remember, dentin is tubular. Each and every one of those, up to 52,000 tubules per square millimeter, is large enough for bacteria to get in. So it's not impossible that we can still get an endodontic infection even if we don't have pulp exposure. So that's something to consider when we talk about treatment. Treatment is usually dictated by, again, types of tissues that are exposed. So for uncomplicated fractures, if they're acute, if you happen to have witnessed it, uncommon, unfortunately, that clients have witnessed these sorts of traumas, but if you know for a fact that it is recent, we can do a composite restoration. So we can seal over those dentinal tubules, and teeth do actually have a limited capacity for healing. So those odontoblasts can lay down a different type of dentin called tertiary dentin, and they can seal off those tubules so that bacteria can't get in anymore. It just takes time. So we can help the process along by covering up those exposed tubules with a restoration. If the fracture, as is more commonly the case, is there for unknown periods of time, then radiographic monitoring is appropriate. As long as there's not evidence of death in the tooth, then we can just continue to have that tooth serving its function. We talk about complicated crown fractures, so with pulp exposure. If they're acute, we can always extract, but if the client is particularly motivated, we can preserve the teeth with endodontic therapy or a root canal, as we do in people. Sometimes, if the fracture is very recent or the patient is very young, again, with a wider pulp canal and more soft tissue, more vessels in there, sometimes we can't get the bleeding to stop when we're doing the root canal intraoperatively, so we have to do a temporary root canal first to stop the bleeding, then we have to get them to come back and we do the permanent root canal sometime later, but that's not terribly common. Once we've done the root canal, we can potentially put on crowns in veterinary dentistry as well, if we want to make the tooth as strong as possible, but we'll talk about it a little bit more on the next slide. If it's a chronic fracture, we have no idea when it happened, the pulp looks grossly necrotic, there's always extraction if we're opposed to extraction, and if the tooth is periodontally and endodontically healthy. So if it already has a huge abscess at the base of the tooth, no, gotta go. If it already has significant periodontal disease and has lost a bunch of attachment, there's no point in going through these measures to treat a tooth endodontically that will then fail periodontally. So we always have to kind of assess the status of that individual tooth before we make these advanced treatment decisions, and then plus or minus crown. For crown root fractures, we generally extract those, and that's because when we have a fracture that goes below the gum line, that becomes a plaque retentive surface. So it's just harder to keep those teeth periodontally healthy if the fracture goes below the gum line. With abrasion and attrition, again, kind of as for above, if there's pulp exposure, extraction or root canal, if the tooth is otherwise healthy. If there is no pulp exposure, then radiographic monitoring is appropriate. So with this triptych here, it kind of shows the treatment process of a dog that not only got a root canal, but also got a crown. So this is a left mandibular canine tooth, and you can see here the enamel is the whitest tissue on the outside surface. The dentin is a little bit deeper and more tan in color, and then centrally we have that kind of red-brown, which is the pulp exposure. I find that even clients who have had root canals themselves don't necessarily fully understand what is involved with endodontic therapy, and it's the same process in veterinary species. So what we do is we actually mechanically and chemically debride all of that pulp material out from the pulp cavity itself, so that we only have nice clean dentin left. We do that with metal files, so we insert them and take them out many, many times to kind of scrape out all of that material from the pulp cavity. And then we actually alternate with chemical debridement, which means flushing with dilute bleach, which sounds unappealing, but it's actually excellent for dissolving any lingering soft tissues and for disinfecting. So any bacteria that are already in there, we can clean out that pulp canal. Finally, if we want to make this tooth as strong as we possibly can, we can consider prosthodontic therapy or application of a metal crown. We do this more frequently in working dogs. The AMC has a strong relationship with dogs that work for the NYPD or counterterrorism. If the dog needs the tooth for its livelihood, great. We will go to extreme lengths to save that tooth. But some companion animal dogs are just hard chewers, and maybe this will protect that tooth going forward, or maybe the client's just very motivated and the patient is otherwise a good candidate for anesthesia, then absolutely we can consider it as well. But it is a process that we can't veer away from once we start it. So to prepare for this crown, we actually have to take away more of the natural crown surface. We have to shave it down a little bit, as in people. Then we have to take an impression of that tooth, send it all the way to California, where the lab is that makes our steel crowns. And then they send it back to us, and we bring your pet back, and then we cement the crown on. So if we want to go all the way to prosthodontic therapy, we need another anesthetic episode, and it does cost more. So it's something to consider. If you, again, tooth, client, patient, if you have a geriatric Chihuahua that already has progressive heart disease, and you say, I am desperately interested in doing a root canal on this functionally useless first premolar, I'm going to politely decline. Could we do it safely at the AMC? Probably. We have a world-class anesthesiologist here, fortunately, but it's not in your dog's best interest to do all of these procedures that will prolong individual anesthetic time and will potentially require subsequent anesthesia. Root canals have a very high success rate in dogs and cats, about 95% in veterinary medicine. That being said, it's not one and done. So we do recommend periodic radiographic monitoring under anesthesia going forward, first from 6 to 12 months and then thereafter based on patient need. So we wouldn't want to take that little Chihuahua and commit it to more anesthesia in the future that it does not need. Conversely, if I explain all of this to you and you are not remotely interested, you just want to take out the tooth, you never want to see me again, that's fine. No tooth, no problem. I'm happy to extract that tooth. My goals are for your pet to have a functional and pain-free mouth. Fortunately, within my specialty, I have a number of viable treatment options that all achieve that goal. So whatever we come to together in agreement, I just want it to be an informed choice for you. So if you're not interested in a root canal, great. I will take that tooth. It will heal, no problem anymore. Prevention, as in periodontal disease, is easier for dental trauma, but sometimes more easily said than done. Things like vehicular trauma, fall from height, animal-on-animal violence, we can't always avert those things, unfortunately, but a lot of dental fractures are quite preventable. And that's because, again, the animal product market, unregulated, there are a lot of things that are easily available that are actually not good for your dog's teeth or your cat's teeth if they're a chewer, I guess. Things like bones, antlers, hooves, even hard plastic toys. All of those will break teeth. Tennis balls seem innocuous, but those things are like sandpaper. They will wear teeth down. So we shouldn't encourage any of those things if we want to preserve the integrity of the dog's or cat's teeth. So a bit of a rule of thumbnail. Sorry, it's a very punny presentation this evening, but if you cannot indent a potential chew toy with your thumbnail, it's probably too hard. If it looks like it would hurt if someone hit you in the knee with it, it's probably too hard. So err on the side of caution. I saw a cat in one of the participant screens earlier, so I know there's at least one cat person here in this evening, which is great. Remember, cats tend to get ignored, unfortunately, in veterinary medicine, and veterinary dentistry is no exception. But as we've already seen, periodontal disease is quite prevalent in cats, but cats have their own sort of unique problem that is definitely worth your awareness as a pet owner. Dogs will resorb their teeth to some extent for various reasons as well, but cats really do it for reasons that we don't understand at all yet, which is very frustrating. And greater than 65% of cats will be affected in their lifetime by at least one of these lesions. So the majority, again, periodontal disease, tooth resorption, cats need to come to the dentist. We see a lot here, but we should be seeing more. Again, the etiology of this is unknown, very frustrating, and because we don't understand why it happens, that means that we can't really treat it. All we can really do is take out those teeth, unfortunately. Clinically, what that tends to look like is this sort of soft tissue. It looks like the gingiva, but it's actually more like granulation tissue, starts to crawl over the teeth. So if you notice that, tell your veterinarian. Radiographically, it looks like what it sounds. So the teeth are being resorbed, they're being moth-eaten. So they will have these holes, literal holes in them, because unfortunately, cats decide to, in adulthood, switch on the same enzymatic cascades that are actually useful and appropriate in earlier in life. So when deciduous teeth are exfoliating, and if you remember your own teeth from when you were a kid, the tooth that comes out of the mouth is actually just the crown. So the body has already resorbed most of the root to allow the adult tooth just to kind of harmlessly help the deciduous remnant to exfoliate. Cats turn on that same process in their permanent teeth, which is obviously undesirable. And when they break into the pulp cavity, then that becomes quite painful. No one loves to think about extraction, but it's much better than chronic pain. So have your vet take a look and extract any teeth that are affected by tooth resorption. So I warned you about various types of dental disease that are very prevalent in dog and cat mouths. How do you, as the pet owner, detect it? There are some signs that are attributable to dental disease, no matter how we're defining it. Halitosis, not normal. Not normal for dogs to have rank foul breath. That is, remember, those volatile sulfur compounds from those darn gram-negative aerobic bacteria. It's not normal. It's a sign of periodontal disease. Reduced appetite, reluctance to chew, favoring chewing on one side, scratching at the face. Certainly if you see things like mobile teeth, bleeding or receding gums, calculus deposition, those are all signs of periodontal disease generally. If you see a swelling with a disgusting draining tract out of the tooth or the cheek, that can be referable to dental disease. Hypersalivation, hiding, sneezing, nasal discharge, nose bleeding if we have those oronasal fistulas. Unfortunately, the most common clinical sign is nothing at all. So not having any identifiable signs of dental disease 100% does not preclude the presence of even potentially quite severe disease. So just because you don't notice it doesn't mean it's not there. We should definitely still have our annual exam with our veterinarian and have them take a look in the mouth. Just to kind of summarize everything we've been through, hopefully you're still awake. Dental disease, again, no matter how we describe it, is the most common disease, period, in dogs and cats. It's worthy of our attention. It does negatively impact systemic health and quality of life. Periodontal disease specifically is chronic and progressive if we don't treat it. Halitosis is not normal. Home care, though sometimes challenging to implement, does reduce our need potentially for extractions, but not always. And it does not preclude needing to come in for regular professional evaluation. As in us, we still have to go to the dentist even if we're brushing our teeth. Advanced treatment options are available for moderately affected teeth, depending upon the individual tooth, the client, and the patient. Many dental fractures can be avoided, and again, advanced options available for particular teeth, clients, and patients. Unfortunately for cats, extraction is the only viable treatment currently for tooth resorption, but I promise they'll feel much better without those teeth. And again, the absence of clinical signs does not mean that there's not significant disease present. So resources that I want you to be aware of and to go visit, the American Veterinary Dental College. So that is the governing body that admits veterinarians into the specialty of dentistry and oral surgery. They have a pretty excellent client education webpage, and anesthesia-free dentistry. I do want to take a moment to talk about it because it is offered even within New York City, which I think is incredibly unfortunate. The American Veterinary Dental College, the American Veterinary Medical Association, the American Animal Hospital Association, all these large bodies have come out with position statements against anesthesia-free dentistry. You cannot safely perform dentistry in a conscious veterinary patient. It's unkind to them, it's painful for them, it's unsafe for them. The eye, the brain, big vessels, they're all very close to the teeth. We don't want to stick sharp objects in a conscious dog or cat's mouth. It's unsafe for the operator. No one likes being bitten. And we cannot adequately diagnose or treat disease in an awake patient. Say no to anesthesia-free dentistry, please. And then there's the VOHC, always available there, if nothing else, as a shopping list for things to incorporate into your home care. Finally, I am thrilled to take questions if anyone has any. So just
Thank you so much. This was a great presentation. We do have a lot of questions, so we'll go through them. I guess about toothbrushing, we have a bunch. Basically, how often, how long to brush the teeth, how frequently and how often, and using like the rubber finger brush. Is that okay?
Finger brushes, sure, if it doesn't seem like something that your pet is very reactive to. I do think a very soft, densely bristled human toothbrush is probably more effective for mechanical removal. So I would go to the human toothbrush just so we can maximize our benefit. Frequency, again, it's really about that pathogenesis of disease. So we're immediately essentially developing plaque biofilm, but we have to act before it mineralizes into calculus or tartar. We are going to be much less able to, with something like a toothbrush, just brush away calculus and tartar. So we need to brush teeth at least every other day, because when we get to that 48 to 72 hour window, we start to mineralize into calculus. So at least every other day. I do burst a lot of bubbles, I think, when clients are like, I brush once every week and it's a struggle. I'm like, okay, don't bother. You know, it's not helpful that infrequently, unfortunately. I wish it were, but we need to think about what we're actually fighting in terms of disease process.
And what about for cats? I know we were talking about how we need to do a video of cat brushing, but you know, it's harder, but does that prevent it? It doesn't necessarily do anything for tooth resorption, right? But you know, tell me about.
No, I don't think there's any compelling evidence that it will prevent tooth resorption. I think I can rationalize it and say that if we have less inflammation locally, then we can maybe not trigger whatever unknown trigger is pulled when we start resorbing teeth. But we know that cats are as affected by periodontal disease as they are by tooth resorption. So it's really a 2-for-1. I would definitely recommend it in cats. It's not easy, perhaps even less achievable in some cats than dogs, but I think it's worth trying in every cat because I think every cat could benefit. That being said, if it's not doable, then fine, dental treats. You know, I think greenies, those little crunchy things that some cats are very addicted to for some reason, I do not know what's in them. I believe those are on the VOHC list of approved products as well. So anything that can add a little bit of crunch can help. It's not going to replace toothbrushing. There is a conversation about diet choice, and some believe that a kibble diet is going to be more abrasive and be more effective at removing plaque than a canned diet. And it gives me pause to recommend a kibble diet in cats just for periodontal health. I do love cats. I self-identify as a cat person, and I would much rather have my cats be slim and trim and better hydrated on a canned diet than obese and diabetic and a little bit drier on a kibble diet, which we tend to see. So if we have to make a choice between diabetes and teeth, fine, the teeth can go. It hurts me a little bit to say that, but if we're prioritizing, then a cat can live much more easily without its teeth than with diabetes, if we're being kind of blunt. So I personally do not recommend transitioning to a dry diet just to potentially help periodontal disease in cats, but I think feeding a canned diet and maybe subtracting whatever calories you're instead introducing with a few greenies every day, great. I think that's a reasonable compromise.
Great. Okay. And if you could talk a little bit about, I know you mentioned that both cats and dogs do very well without teeth, and certainly better than it being painful. Is there anything, to recommend to get them used to it, or, to adjust to
That's
no
a great
teeth?
question. And it's always, I think it's always the first one we get when we say, oh, sorry, we've not paid much attention to Rover's dental health throughout his life. Now he's a 14-year-old Chihuahua getting his first dental, and I have to take out 32 teeth. It happens here semi-regularly, and clients are understandably a bit gobsmacked when I mention that number. However, even if we have to take every tooth out of the mouth in a dog or a cat, there's a reason for it. And they're always, once they recover from the oral surgery, they're always going to be more comfortable than chewing on a mouthful of mobile, gingivally recessed, rotting teeth. Clients always say, can they eat? I'm like, well, they've been managing to eat with the cesspool, so I think they will manage without teeth. It's just a matter of the healing period. Fortunately, it's quite rapid healing in the oral cavity. So I think there is some adaptation. I imagine, yes, chewing food without teeth probably feels quite different, but it's not something that we actively have to encourage in most patients once they're just not painful, or when we are adequately controlling their pain postoperatively with multimodal anesthesia or analgesia that we send home. As long as they're comfortable enough, they will work it out mechanically. Cats tend to be very much unbothered once they are toothless. Dogs, again, I don't think there's any functional impairment or any welfare consideration, but sometimes, not sometimes, all the time, when we take out the mandibular canines, they're the teeth that are really keeping the tongue in the mouth. So dogs without any teeth, their tongues will tend to kind of loll out of their mouth a little bit. It's not meaningful to their quality of life. Some clients find it a little bit aesthetically displeasing, but it's not, again, anything that will prevent them from living a normal, healthy life. Some dogs, though, I think one thing worth considering, especially if they have a longer coat, their upper lips will tend to kind of fold into the mouth without the upper arcade to keep the cheeks and lips out of the mouth. So if a dog has a very wiry coat or a long coat, and then its lips tend to slide into the mouth, that can be very irritating to them. So if you have a small breed Maltese with a lot of beard, we take out all the teeth and you find that they're like, like gnashing their teeth kind of, or what used to be their teeth, gnashing their jaws compulsively at home. I think that's probably because the hair is irritating it. And once we point that out, and once the groomer just keeps the lips nice and trimmed, problem solved. So there are very few, if any, very significant consequences to a dentulous life after dentistry.
Great. Okay. We also have a question about small dogs, and since they're more prone, should they get exams more often? And really, how often? Is it yearly or in general?
That's also a good question. I think any dog, generally at any age, I think an annual examination is an appropriate recommendation. Certainly when we get into adult and senior, then annual or semi-annual. As a specialty service, it's a little bit different in that a lot of, especially the dental disease we've been discussing tonight, can actually happen in the realm of primary care. So primary care can handle a lot of primary care dentistry. So I think it is usually a conversation, just because I don't see pets for their routine annual exams, it's usually a conversation first with their primary care veterinarian at their annual exam. If they've looked in the mouth and they say, oh, I see some gingivitis, I see some calculus, I see some evidence of periodontal disease on conscious examination, then we would recommend anesthetized evaluation. The frequency with which the anesthetized evaluation needs to happen, again, yes, probably more frequently in smaller breed dogs. It's somewhat on an individual basis. I think what we end up kind of doing, the pattern that we end up falling into is, okay, we welcome the mouth in whatever state of mess that it is when first time they see us. We do a cleaning, we take out whoever needs to go. We usually recommend, okay, let's say in a year we do this again. At that point, we can compare. We have a baseline and we can compare the dental x-rays from that year later. If your individual dog has lost very little ground from periodontal disease in that year, maybe we can push it back. Maybe it doesn't have to be yearly. Maybe it can be every 2 years. If it's a large breed dog, a golden or a Labrador, maybe it can be less frequently. It shouldn't be twice in a lifetime. I don't mean that infrequently. But it's somewhat kind of individual. And I think that's kind of what we do. And that's our recommendation. Let's see how much ground we've lost in a year. And then we can say, oh, maybe we need to come back in 6 months, or, okay, whatever, maybe a year and a half. And so there's not a great rule of thumb. I think it's based on initial baseline data and then seeing how the individual patient develops further subsequently. If we do a cleaning and you brush the teeth every day in the interim year and the mouth looks pristine and exactly the same from the last year, great. We can prolong that interval a little bit.
That's what I was thinking. Once the owner proves that they will be taking care of the teeth, right? So yeah. On the note of the hair in the mouth, you have a question about that her dog has a long mustache, and she's heard that having the hair cut into the mouth is somehow bad for the teeth. Is this true? She tends to lick it into her mouth.
Sorry, so cutting the hair is bad, or leaving it long?
Having the hair, having the curl into her mouth is bad for the teeth.
Yes. So I think if the hair is, if I'm understanding correctly, and the hair is kind of curling into the mouth, then yes, that can be, I think that can contribute. I think it's probably irritating if nothing else, but it also is kind of another surface onto which debris and undesirable things can accumulate. And so if we're kind of chewing on hair, we do see a frightening amount of hair impacted into periodontal pockets. So for that reason alone, I would want to keep it a little bit shorter, just so we're not like directly inoculating the periodontium with hair, because that will then kind of contribute to the biofilm, etc. So I think yes, it's reasonable to actively avoid chewing on hair when possible.
Okay, we have many questions also about anesthesia, which you did cover, but just obviously people saying how scary it is and how worrisome, and dogs with seizures, older dogs. And then we also have a question, how safe is it at AMC? So we can.
Yes, excellent cluster of questions. And I think that is, so contrasting primary care dentistry versus specialty dentistry, which was kind of all about the conversation last year. I think we end up seeing a lot of cases that are becoming advanced in age, and age in and of itself is not a contraindication to general anesthesia. That being said, older animals their metabolism, as our metabolism, slow with age. So an older animal that's otherwise completely healthy may recover more slowly from anesthesia because they are slower to metabolize those drugs, but that is not reason to preclude intervention. That being said, comorbid disease tends to also accumulate with age. So our older small breed dogs love to have valvular disease, unfortunately. So we see many, many patients that are referred explicitly because their heart disease has progressed to a point where the primary care veterinarian is no longer comfortable anesthetizing them. That's entirely reasonable. We do see a lot of otherwise uncomplicated dental disease that it's more about managing anesthesia. So that's a reasonable reason to be referred or to self-refer to the AMC. We do have an anesthesiologist, a boarded anesthesiologist, Dr. Melissa Smith. She's amazing. That is uncommon to have a veterinary anesthesiologist in a vet hospital, even in New York City. So having an anesthesiologist, I think, does make the AMC a very good place for your pet to be anesthetized for whatever the reason. And we can modify our drug protocols based on renal disease, heart disease. We can make it safe to anesthetize the vast majority of patients, even if they do have other disease processes. And we agree, again, that risk-benefit analysis, it's always a risk-benefit analysis of anesthesia versus rotting mouth. So we are definitely as careful as we can be, and we tailor our anesthetic protocols to each and every patient and their individual need. But we anesthetize patients with heart disease all the time. It does not stop us, as long as it's not, as long as they're not actively in heart failure. But the other week we had 2 patients in one day that had already been in heart failure once previously, and Dr. Smith helped us, induce them and recover them. They both did quite well. So it's not impossible, and especially if we have things like imminent jaw fractures or disgusting long-standing oronasal fistulas, then yes, those things are clear and present dangers to quality of life. So anesthetizing those patients is sometimes very much worth it. I forgot some of the other questions about anesthesia. Sorry.
I think you answered it. Okay. Seizure. Again, it's individual to right. That's
seizures.
Yeah, but
don't preclude anesthesia. Yep, we anesthetized epileptic dogs frequently.
Okay. We have a question about should cats, and I imagine dogs, have a heart evaluation before anesthesia?
Yes. So cardiac disease, again, very common, mostly in dogs, but we do see heart disease in cats as well. Anytime an animal has a murmur, I think minimally you should expect us to recommend chest x-rays, just so we can get some sense of changes to the cardiac silhouette, we call it, and to rule out evidence of current heart disease. That being said, for cats in particular, feline heart disease, to me, whether it's reasonable or not, it's a little bit scarier than canine heart disease. So I think cats, I would more strongly recommend that they've had, if we do have a concern for cardiac disease, that they do have an echocardiogram prior to anesthesia. We have a cardiology service here as well. So it's not always something we can accomplish in the same day as a procedure, but if we do recommend it, then we can usually make it work. And that is helpful in informing our anesthetic protocols. So yes, if a cat has heart disease and has not had a recent echocardiogram, that is something we would likely recommend prior. But we do anesthetize cats with heart disease regularly, and it is not something that is going to stop us if they have a very painful mouth and we feel that the risk of anesthesia is worth the benefit of intervention.
Okay, great. And then I wanted to also just ask about exotics. I don't like to neglect them too much. And I know we have the exotic service, but yeah, I feel like just
So we do have an exotic service. Exotic pets do have dental needs as well. At this particular institution, the exotic service tends to deal with most of their dentistry needs on their own, but we have helped them on cases like mini pigs and rabbits with very bad abscesses. So they will come over to us and help, and we will help sometimes if they request that help. But we don't tend to see companion exotics primarily through our service. We do go to the Bronx Zoo fairly often, which is nice. I've gotten to help with root canals in a tiger and a gorilla, extracting a boar tusk, and helping with an aardvark that had a pathologic jaw fracture secondary to dental disease. So we do see some quite strange creatures, just not generally in our day-to-day.
Okay, great. Okay, I know it's getting late now. Thank you for sticking with us. A couple more questions. Not to be plugging AMC, but just do you recommend getting a dental check at a specialty clinic like AMC or at a regular vet? When to come there? Maybe it is, as you said, if they're older, maybe what situations are, where you think?
That's a great question. And I definitely, again, harped on that last year because I do 100% agree that it's important. I think the majority of primary care dentistry can be done in primary care, assuming that the clinic is well equipped to provide good dentistry. That's a big caveat, unfortunately, and that the ABDC client education page it literally has a list of questions that you can ask your veterinarian. Like, do you have dental x-rays? Who is performing the surgery? It should be a doctor, not a nurse. You should have dental x-rays. We cannot do dentistry safely without pre and post-operative radiographs. A nurse should be monitoring anesthesia. We should not, having one person do the work and anesthetic monitoring, that's not appropriate. So as long as you can check a number of boxes to make sure that the dentistry that's performed by your primary care veterinarian is high quality, and if your primary care veterinarian agrees that your pet is not a higher risk from anesthesia, then I think it's entirely appropriate, and many of these things can be dealt with in primary care. That being said, things like guided tissue regeneration, root canals, crowns, those are all us. So no one out in primary care is going to be doing that generally. So if you are interested in those advanced preservation techniques, then you would need to come to a specialist, which for better or worse is still us, still just the AMC within New York City. Yeah, sorry, did that answer the question?
No, and then just more concretely, we have a question, just how to make an appointment. Do they need to come through an RDVM or can?
No, they don't need to. You can contact the appointment desk through the AMC and make the first available appointment. The first available appointment, I think at this point, may actually be in June or July. So that's the problem with being the only specialty service, is that we book out many months ahead. It's a mixed blessing, but we do have a wait list. So if your pet has a pressing need, if it's more urgent than just we need a cleaning, you can, once you've made that obnoxiously far in the future first available appointment, you can also be asked to be placed on the wait list. And then we have a wonderful service coordinator, Monique. She's tireless, and she combs through that wait list constantly to prioritize who needs to be fit in. If you're on the wait list and your need is genuine, then we can usually get those cases in within a few weeks rather than months. We do our best, but we're only so many people.
Okay. And we'll send out that information tomorrow, the numbers and links to this presentation. People are asking about it, and we definitely will have this posted tomorrow, so you can watch it again. Let's see, one more, just if, can people scrape off the plaque on their dog's teeth themselves in between?
I wouldn't recommend it. One, you do potentially risk damaging the tooth. If you're using some form of like plier type appliance, you can fracture the tooth and then you'll be sad. And remember, if we think about periodontal disease, whatever's above the gum line is much less important than what's below the gum line. And there's no way you're going to be able to safely treat below the gum line in an awake patient. So if you chip away the calculus, if you have, like, that's part of the problem with non-anesthetic dentistry, is that you tend to be lulled into this false sense of, I'm treating periodontal disease. I have had several patients semi-recently come in and say, I've been getting non-anesthetic dentals for years, and yeah, supragingivally above the gum line, the teeth don't look terrible. Still took out 20 teeth though, because no one's been looking below the gum line. So it's a false sense of security to be just chipping away at the plaque above the gum line, because it's much less relevant to the disease process and the attachment loss below the gum line.
Wow, yeah. Couple more questions, several questions about the aggressive chewers. We've said no antlers, no, and actually probably for aggressive chewers, having one myself, they're probably the worst to have them because they will fracture a teeth, like, right? So just, again, we have the VOHC, we'll send that tomorrow, but no antlers, maybe just reaffirm that. What about, someone asked about carrots too, or raw veggies.
Oh, carrots. They said carrots. I was like, they don't have teeth. I don't know what to do with you. Carrots are fine. They're probably not too hard. They are higher in sugar content though. And I did briefly mention, I think that we tend not to see cavities in veterinary species. Something like fewer than 5% of dogs will have true dental carious lesions. And that is to some degree a difference in like salivary pH and oral microbiome, but also because our dogs tend to not eat the sweets that we do. And when we eat high sugar foods, then the bacteria in your mouth will metabolize that sugar and excrete an acid. So that's where we get dissolution of those enamel rods with those acids that are produced by bacteria within the mouth. This tends not to happen in dogs because of them being dogs and because of their diet. That being said, I have seen some cavities in dogs since I've started my residency, and it tends to be in dogs that eat a lot of bananas and ice cream. So I would probably say no to carrots just because they are sweeter. And I think even from like a training perspective, things like green beans and blueberries, I think are generally kind of recommended as a maybe almost like a glycemic index type thing, that they're a little bit less high calorie for rewards for dogs. So I would avoid carrots, but that's not necessarily a very evidence-based recommendation.
Okay. And how about bully sticks?
Bully sticks tend to work. Once they soften up, then they're not so much in the danger zone. I think bully sticks, as long any sort of chew, any sort of dental chew, it can be hard to find one that actually works for your dog. It's about what they will actually want to eat, what they will eat without getting GI upset, what they will not inhale and have an esophageal or gastric foreign body. So when you're introducing a new dental treat, monitor your dog and make sure that they're not eating it at all in one bite, because then we're not accomplishing anything. They have to actually chew on the dental chew for it to approximate toothbrushing. So if they inhale it, it's not doing any good. So size them appropriately and find one that is enticing enough to your dog that they will actually want to use it. But the VOHC has a number of options, some of which are actually quite dense. So I think they're like kind of starch-based products. So even for heavy chewers, I think there are some dental chews that may be pretty resilient for those heavy chewing dogs.
Okay. You have a question about, I know you were saying that toothpaste isn't even really necessary. We do have a question though about hydrogen peroxide. No. Yeah, that's what I thought.
Don't do it.
Okay, yeah, don't do it. Okay. And we have many, many compliments, both on the presentation and the wonderful care that you've received at AMC and with you specifically. So thank you again. Thank you everyone again for joining us. And thank you so much, Dr. Ford. This was wonderful. And as I mentioned, we'll be sending it out tomorrow so everyone can watch it again. And thank you again. Thanks, Kimberly. And everyone have a wonderful night. Thank you.
Thank you guys very much.